Let me get started here. You know, when I first got the invitation to come speak, I thought maybe y'all want to hear about my 45-year organic garden, which is this, or my 2 acres of organic blueberries, which is this. But you really asked me to talk about an issue that's not unique in the history of agriculture, where a crop will get wrapped up in politics and religion and culture and criminal justice. And so, you know, I could have come here today to talk about a plant that was considered both a deadly poison and a powerful aphrodisiac, a plant whose growers suffered jail time, fines, the loss of their property, even being burned at the stake. But I'm not here, oops, now it's not working. Not here to talk about the tomato. People were burned at the stake at one point for growing these things. I also could have come to talk to you about a plant that's been the mainstay of small farms throughout the South, but a plant that ends up killing 1 out of every 3 people who uses it, and that's tobacco. So it's interesting how long we vilified marijuana and encouraged tobacco production when they have diametrically opposite health effects. I'm here to talk about cannabis, and specifically medical cannabis, not hemp, not recreational cannabis, but just medical cannabis. And I hope some of you have had the opportunity to get to know plants like these up close and personal. It's an absolutely magical plant. I've grown it since 1971 and have enjoyed everything about it. But if you're a medical cannabis farmer, what you're actually producing are trichomes, which are the small, glassy-looking nodules on the plant. That's where the medicine is. Between 60 and 100 cannabinoids have been identified in these trichomes, and these are produced most heavily in the unflowered female plants. Again, absolutely stunning pictures. My own experience with medical cannabis sort of parallels my career. In 1977, I was running a project for asbestos workers in Texas as a CDC grantee, and there was a meeting of the grant recipients, and one of the other teams had been studying folk medicine in northern New Mexico, in both the Hispanic and American Indian villages, showing the herbs that were being used, and 3 of the herbs they showed were 3 varieties of cannabis that had been introduced in those communities 4 centuries ago. When I was at the National Cancer Institute in '79, the clinical division was doing placebo-controlled double-blind studies of marijuana to reduce chemotherapy and reduce nausea. In 1979, the study was unblinded not because the people getting active pot got high, but they got an immediate and profound reduction in their nausea. And so they could tell almost within 2 minutes that they'd gotten the active ingredient. In 1991, when I set up the first research unit focusing on substance abuse as a public health problem in the New Mexico Department of Health, I decided to start separating marijuana from all other illicit drugs when we were discussing substance abuse. Because when they're thrown together, about 80% of the illicit users are marijuana users, and that's all. We really needed to separate it, and we continue to do that to this day. In '92, I was a congressional advisor on substance abuse under President Bush 1, which extended under Clinton. And a sizable minority of our advisors, even back in '92, recommended rescheduling cannabis. In 2002, Gary Johnson, the governor of New Mexico, asked me to do a white paper on creating a marijuana industry for New Mexico. I finished the paper the morning the raid occurred, and so when they left my home after 8 hours, the police also took a copy of the white paper that I had just written for New Mexico. All the while this was going on, I grew and provided to HIV/AIDS patients and cancer patients for 15 years in Tennessee with no problem. My sheriff learned early on I was growing, but he also learned that I wasn't selling it. He got to know the people I was, or knew some of the people I was providing to. So for 15 years, I was not bothered. In 2002, I refused to sell to a local dealer. He turned me into the Marijuana Eradication Task Force, and the rest is sordid history. But again, it motivated me to become more of an activist around this issue. And Jefferson Smith, the character in Mr. Smith Goes to Washington, is my favorite role model as I go up to the legislature year after year, pleading with them to move us forward. In 2010, I rewrote our bill in Tennessee, which last year was called the Coon Medical Cannabis Act. And for the first time, wrote a bill that focused on the needs of farmers. No other state had ever really considered the role of farmers in this. And, Tennessee lost 15% of its farmers just between 2005 and 2014. The farms, as many of you know, are really undergoing a transition, and cannabis would halt, I think, this rapid move away. Now, I'm going to go through some information very quickly on why we should be behind re-legalizing medical cannabis. Some of the strongest statements about the safety of cannabis are up here in front of you, and these conclusions that it's one of the safest therapeutically active substances known to man. These conclusions were made by the DEA's own administrative law judge, Francis Young, after hearing 2 years of testimony recommending that it be reclassified and having his recommendation overturned by a political appointee. In the safety realm of things, an oral LD50 is the amount of a substance that it would take to kill 50% of the people who were exposed at that level. You see all these, 1/20th of a gram of pure nicotine is enough to kill 50% of the people exposed. There's no known LD50 for marijuana. And over the years, the principal route of ingestion, which is smoking, has been made safer by the introduction of vaporizers that allow people to inhale the vapors without being exposed to any carbon monoxide or tar. This has been a medicine for 5,000 years. The first known medical textbook in China identified cannabis as one of their major medicines. It's been used in a variety of cultures, including in our own country. And tincture of cannabis was a very important component of our medical pharmacopoeia for years. Most people aren't aware that when the government first started pushing to make this an illegal substance, the American Medical Association was very much against it. They polled 30 pharmaceutical manufacturers, 29 of them didn't want this to be banned. They spoke out against the laws, only to have their statements completely reversed in the debate by having the proponent of the bill say the AMA supports the ban, when they were one of the few that stood up and said, no, we don't. Over the last 20 years, there have been more than 20,000 peer-reviewed medical research articles. They're now being published at a rate of about 2,000 a year. And we've identified cannabis's beneficial effects for a number of conditions: nausea reduction, appetite stimulation, analgesia. Mediating the progression of the disease is a really powerful line of research that we should have been pursuing for a long time now. It has antidepressant, antispasmodic, and vasodilating abilities or factors. Two major institutions in this country, the National Institutes of Health, the Institute of Medicine, and the National Academy of Science, of which I'm a former member, and the Great Britain House of Lords, all concluded in the early 90s that the evidence was clear, that cannabis played an important role. And since the discovery of what's called the endocannabinoid system, turns out our bodies already produce cannabinoid-like substances that serve the purpose of system balance, homeostasis. That's why cannabis works so well with so many different conditions, because it mirrors this natural system that we have. The activity towards getting rid of reefer madness is really accelerating. Since 2010, 10 more states have established medical cannabis programs. If you include the states that have passed the Charlotte's Web CBD-only laws, you can add another 11 states. So we've got 34 states that have legalized some aspect of medical cannabis. The VA has stopped kicking VA patients out of their services if they test positive for pot in states where it's legal. The National Cancer Institute acknowledges its benefits. 4 U.S. governors have petitioned the Department of Justice to reschedule. For the last almost 2 years now, the Department of Justice has basically had a no interference policy with lawfully established growers and providers in legal states. And last year in Tennessee, 2 separate surveys showed 75% of our voters support reestablishing a program. In fact, here's the visual map. Only the gray states have no provision for medical cannabis. Just in the last 2 months, the National Highway Traffic Safety Administration came out with an exhaustive review of the literature, and basically they said if you control for other risk factors, having marijuana in your system does not elevate your risk above having no drugs in your system or alcohol. And the National Institute on Drug Abuse, which has fought for 40 years to re-legalize this, just last week added that statement on the bottom to their website. Now they list a dozen diseases for which it's beneficial, and they even talk about its potential chemotherapeutic benefit, actually attacking and killing cancer cells. We've known that, by the way, since the mid-70s, when the federal government study discovered that, and then the feds pulled the funding and told the researchers they could not release their results. And again, just in the last 2 months, a major study of 10 abusable, both legal and illegal substances. Cannabis was the only substance to be classified as low risk. Look where alcohol is, beside cocaine, heroin, and nicotine. In states which passed medical marijuana laws, this is what happens to the opioid death rate, the opioid overdose death rate. It drops 20% immediately and continues to decline, so that by year 6, we're about 35% fewer people dying of opiate. And that's mainly because cannabis is a very powerful analgesic itself, so patients can substitute. In fact, not only do opioid deaths go down, but after medical marijuana programs are implemented, fatal traffic crashes go down, suicides among young men go down, crime in general goes down, and marijuana use by youth stays the same or goes down. So instead of population risk, we're really looking at a series of population benefits to launching such a program. Okay. The next section will talk about what we're calling in Tennessee the Safe Access Program, which is the program that would be established under the Cruiser-Kuhn Act. Here's what we intend to do in Tennessee. We want to allow patients to obtain cannabis safely and legally as soon as they're eligible for as long as they're eligible. We want them to obtain medical cannabis of consistent, high quality, safe, effective, reliable, and inexpensive. And I'll focus on that in a minute. We want to administer a program that's self-supporting, tightly controlled, and serves those patients. But we also want to provide a significant new legal income opportunity for Tennessee farmers, communities, and small businesses. Our goals, again, it's kind of repetition. Okay. For our bill, we identified 13 conditions that would make patients eligible, and these are those 13 conditions. Abundant evidence for all of them. We do not include in the Tennessee bill a catch-all that allows physicians to prescribe off-label yet, but these 13 conditions would automatically make somewhere between 300,000 and 500,000 people in Tennessee eligible for the program. Including people like Piper Kuzer, one of the pediatric epileptic patients whose families are now flocking to Colorado so that she can obtain cannabis extract. Piper's seizures have dropped 50% since making the move. Her family in Tennessee had her on an anti-spasmodic drug that was costing TennCare, our Medicare or Medicaid program, $60,000 a month for her medicine. And they're now, they've reduced the seizures by 50%, paying $63 a month for oral cannabis extract. So if you're a safe access licensed farmer in Tennessee, we'll have a standardized application process. We want it grown organically, security procedures in place. We're recommending greenhouse or indoor production only, and I'll talk more about that in a minute. Regular monitoring. The model we set up said that if you wanted to grow as little as 150 by 100 greenhouse, you could be eligible. But you could not grow, at least initially, more than 4 of those greenhouses. So that's 1/8 of an acre up to 1/2 an acre tops to start with our program. Now, anyone ever have one of these in your backyard? Marijuana grows beautifully outdoors, as you can see. And I love these plants. In the original California counties, they limited patients by the number of plants that they could grow. So what did they do? They started growing these mega plants. These plants are Blue Dream is the type, is the variety, and they produce 5 pounds of bud per plant. The DEA estimates now the normal marijuana plant produces about 4 ounces of bud, so 5 pounds a piece. In Colorado and other places where they're legal, you will see operations like this. Marijuana is light sensitive, it buds as the light declines. So these plants are in full flowering mode and they're 18 inches tall. As you know, they can be grown with completely artificial input, light and everything else. But this is so much more expensive a way to do it. Here's the way the maximum producer in Tennessee would look, sort of a schematic for that operation, with the middle building being used for storage, clone, growth, a host of other things. The reason we're recommending greenhouse or indoor grow in Tennessee is there are some problems that occur naturally in this part of the world in the fall when the buds are growing. A bud mold and spider mites can decimate a crop literally overnight. But the biggest biohazard is pollen. And your state and my state have now licensed industrial hemp producers who will make medical marijuana production difficult, if not impossible, downwind for dozens, if not hundreds of miles. Industrial hemp produces 40 tons of pollen per acre, and that pollen can go literally hundreds of miles. And when it hits a beautiful medical cannabis plant, this is what it does to the buds. The plant puts its energy into seed production. So it's really going to be a challenge to build both a medical cannabis program and a hemp industry in some state. I'm very much in favor of freeing hemp, but I want to buy the one-way ticket to Iowa, where wild hemp already makes medical cannabis impossible, all the upper Midwest region. That's where I think hemp ought to be grown, and I'd like Tennessee to grow medical cannabis. To me, one of the lingering vestiges of the drug war is the outrageous pricing that's still around medical cannabis. Patients may pay as much as $400 to $800 an ounce, depending on how they buy it. For someone who's already sick and for whom insurance won't cover this, that to me is an immoral vestige to continue. So our goal in Tennessee is to bring the price down to around $100. And this would be the division of that money, 60% of it to the farmer. This model would, we think, grow to a $400 to $500 million a year program by year 3, which would make us the second leading agricultural moneymaker in Tennessee. Our projections are 30 to 50,000 patients in year 1. If we have the large farmers, we're going to need 60 to 100. The smaller farmers, we might need upwards of 500. By year 2, the patient population has doubled. By year 3, it's doubled again. And by year 3, we may need as many as 3,000 licensed supervised farmers providing the need, or serving the need. Now, do we have any basis for comparison for how these programs might evolve? Colorado's gotten a lot of attention for their legal recreational program. They've had a medical cannabis program there for 16 years. And these data are all just from the medical program. They are administered separately out there. There are, last year, 113,500 patients in the medical program in Colorado, 735 licensed farmers, almost 500 dispensaries. Anyone in here know what MIPS stands for? It's marijuana-infused products, salve, oils, those kinds of things. Now, the size range of the legal grows in the Colorado program are as small as 1,000 square feet, but no larger than 40,000 square feet. And the large one there is approaching an acre of land. These producers make from $15,000 to $400,000 per month on their production. So 1,000 square foot operation in Colorado brings that farm $180,000. The large operation almost $5 million. They're still getting paid about $2,000 a pound. So for Tennessee, you might cut those prices in half. But I don't know how many tomatoes you'd have to grow on an acre to make $2.5 million, but a lot. Okay. Now, states like Connecticut have gone the wrong way. They've really over-centralized their program. And they only have 3,000 patients signed up. 3 years into the program, only 4 producers. They're producing terrible pot and charging $400 an ounce for it. And most of the patients up there just use their medical cannabis card as a get-out-of-jail-free card because their program pot is so bad, patients still go to the street to buy pot. And so up there, you don't get arrested if you have to go to the street to buy it. This is not a program we want to duplicate. Now, in Tennessee, we now have 2 bills, though. One that I've talked a lot about, the Coon Safe Access. Another bill that was just dropped on us 2 weeks ago, literally. No one had seen it. The first number is our bill. The second number is the new bill. They want 6 producers, tops, for the entire state. Those of us who've worked in this area for a long time have always been worried about the influence or potential for big tobacco to move in. This is very much a big tobacco model. And they want, if you want to apply under this new bill to be one of the 6 producers, when you send in your application, you have to send in a $50,000 non-refundable application fee. I've worked in government 4 decades. I've never heard of that in my life. So in fact, who besides drug cartels has that kind of money sitting up under the table? I agree very much with President Nelson that our food system and our medical cannabis system belongs in the hands of many family farmers, not under the control of a handful of corporations. And by the way, we were credited last week with killing this new bill because of the kind of public outrage about jumping over from completely illicit to completely corporate control like this. So we do hope we can get people talking about a more scientific, common sense, compassionate approach to the issue rather than 70 more years of reefer madness. Our goal is to, our goals are multiple, but with our bill, we want to turn our farmers from rapidly disappearing from the land to a situation where they can actually grow jobs in ways that almost no other agricultural crop can do. I love this. Sharing in the success. If you blur your eyes a little bit, those all look like marijuana clones instead of little pine seedlings, but maybe someday. And I want our patients to go from having to flee Tennessee to be helped to basking in the Tennessee sunshine, having fewer seizures. This will I want to end this note by saying as much progress as I think we're in the midst of now. And by the way, this Sunday, CNN will broadcast its 3rd hour-long special on medical marijuana in the last year. And President Obama is going to be interviewed as part of that and will say he fully supports medical marijuana nationwide. I really do think we're right on the edge of thousands of marijuana patients being let out of prison and hopefully thousands of people like me being pardoned for what we've done. But we've still got a long way to go. I thought I'd share this with you. Ole Miss just had its contract renewed. The only place that grows pot legally for the government is Ole Miss. They have a contract with NIDA, National Institute on Drug Abuse. They've had it since 1968. They've just been re-awarded that contract, and NIDA has more than tripled its order for pot. Last year it was 250 pounds, now they want 880 pounds. But NIDA wants to pay them $78,231 a pound for that pot. They're receiving a $69 million grant to grow $78,000 a pound pot. And it is, by the way, some of the worst pot I've ever been around. Irv Rosenfeld is a good friend of mine. He's one of the 4 federally grandfathered in patients who still gets 300 joints a month from NIDA, no charge. But if you're ever in a room with Irv when he fires one of those puppies up, leave the room. I mean, it's chemical warfare. It's not good pot. I mean, it's really terrible pot. So, the government, instead of giving Ole Miss $69 million, could just give vouchers to the researchers, tell them to go to Harborside in Oakland or Magnolia Wellness in San Francisco and pay the top dollar, $6,400 a pound, which is, I think, what, 400 an ounce or so. That's probably not the top chart. But 5.6 million would get you the same amount of pot just going to the market. Or you could wait a year or so until the Tennessee Safe Access Program is going at $1,000 a pound. We'll sell it to you for $880,000. In fact, if you want to make it a cool million, I'll hand deliver the pot and give them a case of my blueberry jam on top. But you know, we could solve some of the problems of farmers, certainly patients and others. We might even be able to balance the national budget if we could do those things. Thank you most kindly for this time. This is the way that 45-year-old organic garden looks when it's cooking. And these are the way the blueberries look. My berries are about 4 times more productive than any that the state of Tennessee is aware of, so come see why. And if we all keep working, you know, we can make this a cannabis safe and friendly world again, which is what it's been for all but the lifetime of one old man. And it's time we retire that old man, I think. So thank you for your time and attention and for the room filling up while my back was turned. And now I'm more than happy to entertain questions or comments.